Okay, so when we discuss the wet AMD, sorry, there is an echo. There is an echo. Okay. Okay, so when we discuss the wet AMD, the hallmark of the wet AMD is the neovascularization. I am still in echo. Just we need to stop for a while. Okay. Okay. Yes. Okay. Because I don't want to hear any echo. Still, I am hearing it. My voice. Okay. Me? Okay. Okay. So just show me. Yeah. Sorry, just we need to adjust the voice before we. Okay, just so. I need to go out. Oh, recording. Okay. Okay. So just I need to adjust. Okay, and okay. So I'm sorry for this technical error. Okay, so when we talking about the wet AMD, we are talking about the neovascularization, which is started from the choroid, reaching to the sub-RPE space, and then to the subretinal space, followed by the exudation or fluid that will be accumulated into these anatomical parts. Okay, so in order to see how to recognize the different types of the choroidal neovascularization, first we will discuss each type, how we can identify these types of the choroidal neovascularization on the OCT. The first type is type 1 CNV, which is previously called occult CNV, which is defined in the fluorescein angiography as the area of ill-defined hyperfluorescence followed by ill-defined area of leakage. On the OCT, we can identify the type 1 CNV as the area of irregular RPE detachment with a moderate reflective area just beneath the retinal pigment epithelium. So this is the type 1 CNV. Now, type 1 CNV also sometimes can be seen not in the just RPE detachment, irregular RPE detachment with a moderate reflective area that we call fibrovascular RPE detachment. Also, sometimes we can identify another type of RPE detachment. It's called SIRI, which means shallow, irregular RPE detachment with a space between the RPE and the Brooks membrane. This sign, we call it double layer sign, or we call it non-exudative wet AMD. What's the difference between the two? In the both type, we have the type 1 CNV, but in the first type, we have active type 1 CNV, while in the second type, we have silent type 1 CNV. So what is the difference? Why it is important? Because in the first type, we treat, in the second type, we observe, we don't treat. That's why now we have a new terminology. We call it non-exudative wet AMD, which means we have a type 1 CNV but there is no any intraretinal fluid or subretinal fluid. This is one of my cases presented to my clinic with a blurred vision in the right eye. And you can see in the OCT, we have the area of the RPE detachment with a space between the RPE and the Brooks membrane. So if we go by the OCT angio, we can identify a small type 1 CNV. So this is, we called it silent CNV. And if we go to the flow map here, we can see the high flow just beneath the retinal pigment epithelium. And this type, we don't treat, we just observe. And if we got any intraretinal fluid or subretinal fluid, then we have to treat. Okay, so this is the typical presentation of type 1. What about the type 2? Type 2 CNV, we called it previously as a classic CNV, which is usually identified by the fluorescein angiography as well-defined Lassie hyperfluorescence with a late, well-defined late leakage. And on the OCT, we can see the area, hyperreflective area above the retinal pigment epithelium, not beneath it. And this is, we call it the type 2 CNV. Okay, what about the type 3 CNV? The type 3 CNV, there's many features for the type 3 CNV. First, we got area of RPE detachment, and on the apex of the RPE detachment, we have a hyperreflective foci. Actually, these hyperreflective foci are presenting a migrating retinal pigment epithelium that migrate from the outer layers into the inner layers and stimulate the deep capillary plexus here and to producing neovascularization, as we can see here. And because the origin of this type of neovascularization is not from the choroid, that's why today the terminology changed from choroidal neovascularization into macular neovascularization, because this term fits to the all types of neovascularization. This is exactly the histopathology, how the type 3 CNV, or what we call it now MNV, developed. The RPE start to migrate from the outer into the inner layers, and usually we can see it on the OCT as the area of RPE detachment. And on the apex, we can see there is a hyperreflective foci here, which is presenting a migrating retinal pigment epithelium. So this is the feature of the type 3 CNV, or now we call it MNV. This is the new terminology. It's called Conan terminology. And we can see here that the type 1 MNV, we called it previously occult, type 2 MNV classic, type 3 MNV called RAP, or type 3 CNV. So now the new terminology MNV, which means macular neovascularization. Okay, so the question is why we need to know these types. What's the importance? What is the clinical significance? It's very important to know the types of the MNV because, for example, in type 2 lesion, usually associated with the worse vision. So when we have the type 2 MNV, we get more worse prognosis than type 1. And if we got type 3 MNV, usually type 3 initially responding to anti-VEGF very excellently, but on the long term, we got atrophy. So this is very important. If you treat the patient, for example, with the type 3 MNV, you have to predict at any time you will get or you will end with atrophy. So you have to keep your patient about this progress. So again, before we leave in the subject, just to refresh our memory, type 1 MNV below the RPE, type 2 MNV above the RPE, type 3 MNV within the retina, intraretinal. So just keep these three images in your mind. And there is no more occult, no more classic, no more RAP. MNV, macular neovascularization. Okay, so not any subretinal hyperreflective lesion is an indication of the CNV. It could be another thing. In general, we call subretinal hyperreflective material, we call it SHRM. And the SHRM, it means sometimes different things. For example, in this case, this subretinal hyperreflective material is not a CNV. It's a fibrotic neovascular membrane, macular neovascularization. So this is a fibrosis. In this case, we can see that the SHRM is a blood. While in this case, the hyperreflective material, the subretinal hyperreflective material, it's a pseudo-vitelliform material. So we have to be very careful when we look to the subretinal hyperreflective material. It's not always an active MNV. It could be another thing. Okay, so now we will discuss the OCTA. And in general, we need to know that the OCTA, it's a non-invasive imaging modality acting by tracking the movement of the red blood cells. And usually in OCTA, we can identify two types of the plexus: the superficial capillary plexus, which is located on the ganglion cell layer and the nerve fiber layer. And we have the deep capillary plexus here that found in the inner nuclear layer and the external plexiform layer. And we will take it in detail in the upcoming slides. Okay, what's the importance of the OCTA in wet AMD? We can identify different types of the macular neovascularization through the OCT angio, like type 1 MNV. Usually we can see it like the CFAN configuration, as we can see here. So sometimes the OCTA will be helpful to identify the types of the MNV. In the type 2, the MNV usually seen as the high flow glomerular shape neovascularization, like the glomerulus of the kidney, as we can see here. While in type 3 MNV, usually the OCT angio, usually we can see the type 3 like the small punches of the grass, like the small punches of the grass here, exactly the same picture like here. The OCT angio is also useful to differentiate whether the MNV is active or not active. For example, if you look to this case here, we have the OCT, we have subretinal hyperreflective material here, and I don't know whether this CNV is active or not. So by looking here, we can see that the CNV here, or MNV, usually the vessels are straight. There's no peripheral arcades, no peripheral loops, not like here. Here we have the peripheral looping and peripheral anastomosis. So this is called dead-tree inactive MNV. Here we have active MNV, active macular neovascularization. Also, you can pick up whether the MNV is active or not by looking to the flow map here. If you can see that there is a flow within this subretinal hyperreflective material, this means that this is an active macular neovascularization. If there is no flow, it is not active. And you can see here that there is no flow at all here, just the flow at the area below it, the area of the RPE. Also, the OCTA is useful for monitoring the response to the treatment, especially if you are treating the patient with a wet AMD. And we can see that when you treat the patient with anti-VEGF, we can see on the OCT angio how they get a regression in the size of the macular neovascularization. And this is very useful tool to tell you when to stop the treatment of the patient and to be sure 100% that the macular neovascularization is completely regressed. Okay, so this is one of my cases, okay, and presented to my clinic with a wet AMD, okay. The patient received one injection of anti-VEGF, and you can see with the OCT angio, this is before the treatment, and this is the after the treatment. And you can see here, there is the disappearance of the macular neovascularization. This is the superficial capillary plexus. This is the deep capillary plexus, okay? And this is the choroid. This is, we called it, we will take it later on. This usually, the image usually taken at the level of the RPE, and can showing very nicely the macular neovascularization. And you can see here the disappearance of the macular neovascularization after the treatment. OCTA also sometimes is useful in some cases. For example, if you look to this case here, it's a case of wet AMD, but if you look, it is just a matter of the drusen, okay? You cannot identify the presence of any neovascularization. But if you look to the OCT angio here, you can identify there is a very fine flow over the area of RPE detachment. This indication that this kind of a drusen is a vascularized drusen, and this means that the patient will get macular neovascularization sooner or later. So that's why you have to pay attention to this patient. That's why the OCT angio, it's a very important in cases of the AMD. Okay, now we'll come to the another type of macular neovascularization. It's called polypoidal choroidal vasculopathy. And now in some references, they consider polypoidal choroidal vasculopathy as a type 4 MNV. It's actually an aneurysmal type of type 1 MNV. It is also sub-RPE type, and usually sometimes mistaken with the wet AMD, usually identified on the OCT like a thumb sign, exactly like a thumb. And you can sometimes see the polyps during the sections of the OCT here. You can identify it, or you can see it also here, the polyp under the RPE, and you call it the thumb sign. And it's very important to differentiate PCV from the other kinds. This is one of my cases. This is 62 years old female, medically free, presented with a drop of vision in the right eye. And you can see, if you look to the color fundus images, there is no drusen. However, we got two areas of the RPE detachment with the area of pocket here of subretinal fluid. Okay, and if you go with the in-face imaging, you can see here the polyps. And this is with the OCT angio, you can also identify the polyps here. So this is a case of polypoidal choroidal vasculopathy. That's why the multimodal imaging is very important in some cases in order to reach to the proper diagnosis. Especially, we have no access to the ICG in Jordan, so we can use the other modalities of imaging to pick up some cases. Again, why it's important to distinguish between different kinds of the macular neovascularization. As we mentioned, the occult, the type 1 MNV is not aggressive, like, for example, the RAP or type 3 MNV. PCV than the anti-VEGF. Usually when we have a type 4 MNV or polypoidal choroidal vasculopathy, usually those lesions are very highly resistant to the anti-VEGF. That's why we need to use the combination of anti-VEGF and photodynamic therapy. And sometimes we need to look to the macular neovascularization very well in other modalities like the ICG, which is unfortunately not available in our country, because sometimes if you find a very large feeder vessel for the macular neovascularization, this means this kind of the CNV or MNV will not responding to the treatment. Okay, so just to refresh our memory, if we look to this case here, we can look here that the patient presented here with the RPE detachment, and there is a hyperreflective foci on the apex of the RPE. So we can guess what is this type of MNV. Anyone of the audience? Type 3, yes, excellent. And if you look to the OCT angio, usually we can identify the type 3 MNV, not here, not in the choroid, where? In the deep capillary plexus. Because we mentioned that the MNV type 3 arises from the deep capillary plexus. So when we look to the MNV type 3, we look here, and we can find this sign, like the small punch of the grass. Okay, so this is a typically type 3 MNV. Why, again, it is important? Because this type responding very well to anti-VEGF, but it will end later on with the atrophy, the macular atrophy. So it's very important to pay attention to such cases. Okay. Now, the other important thing we have to look for in wet AMD is the RPE detachment. RPE detachment is very important because it can tell you different things. We have different types of the RPE detachment. The first one, we called it serous pigment epithelial detachment. In this type, if we look to the OCT, the detached RPE will be smooth, dome-shaped, elevated RPE, detached RPE, and there is a hyporeflective space beneath it. This is the typical type of serous PED. Usually we can see it in type 1, MNV, and the type 3, RAP, and in PCV. We have the other one is the fibrovascularized, which means the detached RPE is irregular, not smooth, and there is a moderate reflective lesion behind it or beneath it. And usually this is seen in type 1 MNV. We have the hemorrhagic type, and we have also the detached RPE, and there is a hyper-reflective area beneath it, then followed by hyporeflective area. This is the typically seen in hemorrhagic type of RPE detachment, and usually seen in type 1 MNV, seen also in type 3, and in PCD. And we have finally the drusinoid that will take it. We have the drusinoid RPE detachment. Now, the most important thing is not any case of RPE detachment. It means that their neovascularization. These are the three clinical types of detached RPE. The first type is the huge drusinoid RPE detachment with the pocket of the fluid on the apex. This is the second type, is the confluent drusinoid RPE detachment with low drape of fluid above it. And the third type is the RPE detachment with a small pocket of the fluid at the angle. These three clinical forms should not be given any kind of the injection. Otherwise, you will end with atrophy. Now, the question, how can I be sure that there is no macular neovascularization? In these cases, you can use the OCT angio, and you can make the OCT angio, and you will find that there is no macular neovascularization. So in case if there is no any macular neovascularization, there is no indication for treatment. Otherwise, you will end with geographical atrophy. The injection will induce the atrophy, and you will end with more loss of vision. So these keep in your mind these three clinical forms of the RPE detachment, okay? That will not require any injection. The question is, what is the source of this fluid if there is no macular neovascularization? Now, the theory behind this is that with the RPE detachment, we get a break in the Brooks membrane. So the fluid will escape from the choroid to reach to the subretinal space, okay? So if you do any OCT angio here, you will not find any neovascularization. So that's why we find a fluid, but the source of the fluid is not from the neovascularization. Now, sometimes we can identify over the area of hyperreflective lesion, subretinal hyperreflective material or shrimp, the areas of hyperreflective lesion with a hyperreflective wall like this. These, we called it outer retinal tubulation. It represents a detached photoreceptors that will disorganized photoreceptors, and usually they are sometimes mistaken as an edema. It's not edema because even their level is not the level of the edema, and they should not be given any treatment because they will not disappear with any kind of injection, even if you give the hundreds of injection. Usually we call it outer retinal tubulation, usually seen as a hyporeflective lesion with a hyperreflective wall. So please pay attention to the outer retinal tubulation. Okay, I will not go through these more biomarkers because this is a more advanced level. So just we need to keep in our mind what is the importance of the OCT when we give the patient the anti-VEGF. As you remember, when we talk about the wet AMD, we have three fluid compartments. We have the intraretinal fluid, we have subretinal fluid, we have sub-RPE fluid. When we treat the patient, we give the priority to the intraretinal fluid, then the subretinal fluid, then the sub-RPE fluid. Well, before the era of the new anti-VEGF, like the prolizumab or faricimab, most of the anti-VEGF were dealing with these two compartments. But now with the new era of the anti-VEGF, with the invention of the small molecule anti-VEGF, we're now able to targeting even the sub-RPE fluid. Why we give the priority to the intraretinal fluid? Because the intraretinal fluid will cause more impact on vision. Then we have the subretinal fluid, then the sub-RPE, because the subretinal fluid more tolerable than the intraretinal fluid. So when you treat the patient, you have to give the priority to the intraretinal fluid, subretinal fluid, and then the sub-RPE. But at the end, your aim is to dry the macula as much as you can from all these fluid compartments. Okay, so this is just guidelines for treatment. This is the Euretina guideline, the Royal College of Ophthalmologists, the American Academy of Ophthalmology, and you can see in all the guidelines, there is an OCT. So the OCT is a very important tool when you treat the patient with wet AMD. Otherwise, you will not be able to monitor the patient and to predict the prognosis after the treatment. Okay, so before we finish this part, just I want from you to guess the vision in this patient. This is the patient with wet AMD, and you can see here in the right eye, there is a subretinal hyperreflective material here, okay? But if you look to the OCT, actually, there is no flow. What you can see here, it's not a CNV, okay? Because of there is atrophy, there is unmasking of the choroid. That's why this is not a CNV. So you should not fall in this mistake. If you look to the other eye, what you can you guess what's the vision in this patient? Is good or bad? Anyone from the audience have any idea? Why good? But if you look here to the photoreceptors, it's not very well good. Can you tell me that this is a good photoreceptors? It's very difficult. Okay. The patient saying that sometimes I can see, sometimes I cannot see, which is a little bit tricky. Okay. I send the patient to do the vision, and surprisingly, if you look here, can you identify the photoreceptor? This is, by the way, this is the green line. It's for the marking of the retinal pigment epithelium. Okay. So what do you think now? What, can you guess what's the vision in this patient? Just a guessing. Yeah, poor vision. What can you guess? Just a guessing. 660. Okay. What else? Could be counting finger. Yeah, more logic. Yeah. Surprisingly, when I sent the patient, the vision was 0.7. Okay, we look here, and the patient, this goes exactly what the patient said, that sometimes I see, sometimes I cannot see. If you look to the image of the fundus autofluorescence, you can see very well area of geographical atrophy with just small central island here that the patient able to see. Even with the OCTs, we cannot sometimes identify the photoreceptors very well. But with the fundus autofluorescence, we can identify that this is small island, which is preserved, makes the patient seeing 0.7. So that's why the patient sometimes can see and sometimes cannot see. Try to just put the image on this small area. What's the message from this case? Usually now, the multimodal imaging approach is very important in every case. Okay, usually try to use all of your tools, the OCT, the in-fast OCT, the OCT NGO, the fundus autofluorescence, and even the fluorescein angiography or ICG in order to reach the correct diagnosis, because each tool will give you a part of the puzzle, like in this case. Okay, so take home message, multimodal retinal imaging is always the key for solving your cases. Okay, so now we finish the first part of the wet AMD, and we learned in this part how we identify the different kinds of the macular neovascularization, how we can differentiate between them by OCT and OCT NGO, and how we can predict the improvement after the treatment. Now we're coming to the second part, which is, I think, the most important part in our area, which is the diabetic macular edema. Before we start, is there any questions before we, because still we have a good time? Yeah. Yeah, very good question. One of the questions, whether we can use the fluorescein angiography in cases of the RP detachment. Now, in most of the cases, the using of the fluorescein sometimes will not be helpful, because what we can see in the RP detachment is just area of the hyperfluorescence, which is progressive increase in intensity, not change in the shape and the size, which is because of the pooling of the dye below the area of the detached retinal pigment epithelium. So sometimes the fluorescein may be helpful, but in some cases not helpful. That's why the OCT angio today, in my opinion, is the best option in cases of the RP detachment, in order to tell you whether this kind of the RP detachment associated with macular neovascularization or not. I hope I am answering the question. Any question from the audience before we shift into the other part? This is an interactive course, so please ask, because here just to learn. Yes. Sorry. Yeah. 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 Okay. So one of the audience asking why we give the priority to the some fluid compartments. I will just return to this slide. Now, according to the studies in the wet AMD, they found that the intraretinal fluid have more impact on vision. It will cause more vision loss if you don't treat it. So for example, if I give the patient an injection and I found that the intraretinal fluid is disappeared, but there is a subretinal fluid, I have to treat it, okay? If the subretinal fluid dried and there is a sub-RP element, I have to continue to treat. We need to dry all the fluid compartment, but the most dangerous one is the intraretinal fluid. For example, if you treat the patient, okay, and the macula now is dry, and on the follow-up, you found there is intraretinal fluid. There is a recurrence of the intraretinal fluid. This means it is a bad prognostic point. You need to inject immediately. Otherwise, the patient, you will lose more vision, okay? So that's why we give the priority to the intraretinal fluid first, then subretinal fluid, because patient with wet AMD with subretinal fluid, usually subretinal fluid can be tolerable more than the intraretinal fluid. You can find a patient with wet AMD with good vision and they having subretinal fluid, not like the intraretinal fluid. In other way, the intraretinal fluid is a negative biomarker, is a poor biomarker, while the subretinal fluid alone is a good biomarker, is not bad. But subretinal fluid with intraretinal fluid is a bad biomarker. Okay. Yeah. Okay. Post disabled participant screen sharing. You stop the screen sharing. And why? Okay. بيطلع لي هاي post disabled participant. Okay. لحظة. Okay. Okay. Okay, so I am sorry, just we get a connection problem. Now we will start the second part of our meeting about the diabetic macular edema, the mastering OCT and OCTA in diabetic macular edema. Okay, as we know, the diabetic macular edema is one of the main leading causes of blindness in people under the age of 75. And diabetic macular edema, it usually can occur at any stage of the diabetic retinopathy, and it's considered as one of the major causes of the central loss of vision in a patient with diabetes. The optical coherence tomography provides a very cross-sectional image of the macula, and usually it's very useful to identify the diabetic macular edema and also to assess its appearance and also its shape. Now, when we look to the diabetic, sorry, it's not, okay, okay, I will, just,
which one? This is your this one?
Maybe this one, yeah. It's okay. Okay. My voice is clear. Okay, I will repeat. Okay. My voice is okay. Okay. So, okay. So we'll start again. So now when we look to the diabetic macular edema, actually on the OCT, we can identify 3 types of the diabetic macular edema. The first type is the cystoid macular edema. Usually we find there is a loss of the foveal contour with a multiple hyporeflective spaces, usually found in the outer nuclear layer. So this is the first type. The second type, we called it subretinal neurosensory detachment. Usually we get a serous retinal detachment, usually identified as a bell-shaped hyporeflective space beneath the neurosensory retina. The third type we call the sponge type, sponge-like type. We get a diffuse retinal thickening. So we have 3 clinical patterns of diabetic macular edema: the cystoid one, the neurosensory detachment, the subfoveal neurosensory detachment, and the diffuse retinal thickening. These are 3 types. Okay, in cystoid macular edema, actually, we know the cystoid macular edema is a combination of both the VEGF problem and inflammatory problem. Usually we got destruction in the inner retinal blood barrier with the accumulation of the fluid in the intracellular and extracellular fluid compartments, forming these cystic hyporeflective spaces. What's the importance to look for these spaces? When we get a small cyst, less than 100, usually the impact of the vision is not so much. But if it is large, between 100 to 200, or giant, more than 200 micrometer, it will cause more impact on the vision. So that's why when you have a giant cyst or a large cyst, you have to know that the vision will be very poor. And if you do the OCT angio, you will find the ischemia on the OCTA because of the impact of these cysts. Why? Because these cysts will try to press on the superficial and deep capillary plexus and causing the ischemia. This is the subfoveal neurosensory detachment, as we mentioned it. And today, the subfoveal neurosensory detachment is considered not only as a DME, it's considered as a part of inflammatory biomarkers of the diabetic macular edema. It's usually caused by the accumulation of the fluid beneath the neurosensory retina. And usually we can identify with the neurosensor detachment, the hyperreflective foci that we'll mention it on the upcoming slide. Yes. The pointer is not, okay, sorry. I will return back. I will put the laser, okay. Now it's okay. Now this is the cyst, already you can see it, okay. So this is the second type, is the subfoveal neurosensor detachment here, okay. And you can identify with it the hyperreflective foci. Okay, so the other thing that we have to pay attention for it is the hyperreflective foci. Hyperreflective foci are hyperreflectile lesion, less than 40 micrometer in diameter, having the reflectivity similar to the nerve fiber layer. They found in the inner layers of the retina and also in the outer retinal layers of the retina, and they're not casting a back shadow. So they are not like the exudate. For example, this hyperreflective foci is not like this. This is an exudate because it's casting a shadow. This is a hyperreflective foci, not casting a shadow. The hyperreflective foci first mentioned by Professor Gabriel Koskas. They believed that they are an activated macrophages. Usually they found initially in the inner layers of the retina and then start to migrate to reach the outer layers of the retina. And they are considered as one of the inflammatory biomarkers of the DME. What this means? This means that when you get a more hyperreflective foci, this means that the edema is more inflammatory driven rather than VEGF driven. So that's why the hyperreflective foci is important. The other biomarker today we have to pay attention for it is called DRIL. It's called disorganization of the inner retinal layers. So if we look, just to remember the anatomy of the fovea, these are the inner layers of the retina, starting from the nerve fiber layer, the ganglion cell layer, the outer plexiform, outer nuclear layer. So we can easily identify them. In the DRIL, we are not able to identify the inner layers of the retina. The DRIL is considered as a bad prognostic point. For example, if we look to this case and this case below, these are two cases getting a vitrectomy for a vitreous hemorrhage. And the case number one, the vision was 6.6 because the fovea is perfect and intact. While in the case number two, the vision was 0.1, not because of the bad surgery, but because the patient already had a DRIL. It means disorganization of the inner layers of the retina. We are not able to identify the inner layers of the retina. There is inability to differentiate between the inner layers of the retina. So please pay attention to the DRIL, especially when you decide to treat the patient with the anti-VEGF, because those patients not expected to get a very good visual improvement because of the DRIL. Okay, why these biomarkers important? Because today we have a very new important classification by ESASO, the European School for Advanced Studies of Ophthalmology. Now, in this classification, they took 7 parameters, which is very important for assessing of any diabetic macular edema. The first is the foveal thickness, whether the foveal thickness is normal or not. The size of the cyst, as we mentioned, small cyst, large, giant cyst. The intact of the ellipsoid zone, which means the photoreceptor, whether intact or not. The presence or absence of a DRIL. The presence or absence of the hyperreflective foci. The presence or absence of the subretinal fluid or subfoveal fluid, and the vitreoretinal interface relationship. So based on these 7 parameters, we grade the diabetic macular edema and we give the score for this diabetic macular edema. So please try to pay attention to this classification, and you can return to the literature and you can find the classification in details. And my advice from now, try when you look to any diabetic macular edema, you have to look to these 7 parameters exactly, and you look to these biomarkers in order to classify diabetic macular edema in a very good way. Okay, now we come to the OCT angio in diabetic macular edema. As we mentioned in the previous slides, we have 2 main plexus: superficial capillary plexus and deep capillary plexus. Please keep this sketch in your mind, because I will ask you on the upcoming slide a question about this sketch, which is very important. This is the superficial capillary plexus, which is found at the ganglion cell layer. And this is the deep capillary plexus, okay? Superficial, usually called SCP, located in the ganglion cell layer and the superficial part of the inner plexiform layer. And the deep capillary plexus found in the deeper part. And the intermediate, which is found in between, we will not take it now, just we focus on superficial and deep, but just keep it in your mind. Okay, so OCT angio can pick up actually the early changes of diabetic retinopathy biomarkers. If you look here to the OCT angio frames, you can identify the capillary non-perfusion here in this area. Okay, and also you can identify the microaneurysms. And also you can identify the dilatation and the tortuosity. So the OCT angio, actually, it can pick up the earliest changes of diabetic retinopathy biomarkers. Even if you do the fluorescein angiography to this patient, you will never find these biomarkers. So the OCTA, it can pick up the earliest changes. Now, please pay attention to this case. This is a case of the patient with diabetic retinopathy. This is the fluorescein angiography. And this is the OCTA. This is the superficial plexus. And this is the deep plexus. And you can find there is very severe capillary dropout and ischemia of the deep capillary plexus. The question is, why the ischemia started in the deep capillary plexus? Can anyone answer? By the way, this patient, if you look to the fluorescein angiography and you look into the superficial capillary plexus, you may say that this patient is good. But if you look to the deep capillary plexus, you can guess that the vision in this patient would be very bad. So the question is, why the ischemia started in the deep capillary plexus, not in the superficial capillary plexus? Any?
Choroidal supply.
What do you mean by choroidal supply? No, the question is here. If you look to the deep capillary plexus, you can see the caliber of the vessels is smaller and it's more delicate network rather than the superficial capillary plexus, which is the larger diameter, okay, and more straight, not like taking the polygonal shape, okay? So it's very easy to get a closure in the deep capillary plexus rather than the superficial capillary plexus. So now, when you have a case with diabetic macular edema, and you, for example, the patient coming to you with a very bad vision, you check the fundus, you find there is nothing. You do the fluorescein angiography and find nothing. There is no ischemic maculopathy. If you do the OCT angio, look to the deep plexus, you will find the ischemia that will start it there, okay? Started in the deep capillary plexus before involving the superficial capillary plexus, okay? So this is the cause why the ischemia started in the deep, not in the superficial, okay? You got this point? Okay. So again, why the ischemia started, as I mentioned here, this is a wide field OCT angiography. This is by Zeiss machine. It's a Plex Elite. It's a very great machine now. It's not for the commercial use, it's for the research. The speed of this machine is 200,000 axial scan per second. And you can get a very nice image. And you can see here the peripheral ischemia in patients with the diabetic retinopathy. And again, why the ischemia started in the deep capillary plexus? Because the deep capillary plexus is smaller caliber, more delicate than the superficial, large diameter and more straight vessels.
Can I have a question?
Yes, please.
On the previous two slides,
Yeah.
we've seen with the OCT angio,
Yeah.
superficial angio.
Yeah.
The fluorescein angiography, there is a capillary dropout.
Yeah.
Perfusion.
Yeah.
It's reflected to the deep OCT cuts, OCTA angio cuts, not in the superficial.
You mean this?
Explanation, yeah.
Yeah.
If we this slide, this one, not on the other side.
Sorry, you mean this?
No.
This one? Yeah.
Down.
Yeah, there is ischemia. Yeah, I totally agree with you. Yeah, but that's why the OCT angio can tells you and can show you the ischemia very nicely. Okay, not like the fluorescein angiography, because here, if you look to the fluorescein angiography, yes, you may identify the area of capillary dropout here, here, and here. Okay, but here in the center, you cannot say 100%. Okay, but if you look to the deep capillary plexus, yes, there is a very severe ischemia. That's why the ischemia started in the deep capillary plexus, which sometimes not reflected sometimes by the fluorescein angiography. Okay.
And it's always the case.
No, it started in the deep, but later on it will involve the superficial. Yeah. Yeah, start in the deep. So this is again about the OCT angio. This is the patient with a cystoid macular edema, and you can see here the cyst here on the when you do the OCT angio, you can find ischemia here and exactly in the center. Why? Because the cyst, it will cause the pressure on the capillaries and will causing the capillary dropout, usually because of the cyst. That's why, as we mentioned before, usually the large cyst will cause more bad prognosis. Why? Because the large cyst will press on the peripheral vessels and will causing more ischemia. So this is the question why the large or giant cyst is more causing more impact on the vision rather than the small cyst. Okay, so now we'll come to the new terminology, which is very important now. It's called PIVAC. PIVAC, it means perifoveal exudative vascular anomalous like complex. In a simple thing, what is the PIVAC? PIVAC, it's a hyperreflective lesion with adjacent hyporeflective area. The hyperreflective lesion, it means the microaneurysm, and the hyporeflective space is the fluid. Why we need to identify this kind of lesion? Because this kind of lesion is a very highly resistant to the anti-VEGF. Okay, when you find a PIVAC-like lesion, like this lesion, okay, you should guess that the patient probably will not responding to anti-VEGF in a very good way. So just keep in mind this picture of PIVAC, okay, hyperreflective lesion with adjacent hyperreflective lumen. This is the microaneurysm, and this is the fluid, what we call it, the cyst. Okay, so finally, I will just finish with this beautiful slide. The OCT angio is not only useful in diabetic macular edema, it's also useful to identify the proliferative changes, like, for example, the NVDs or NVEs. And you can see here very nicely the peripheral neovascularization. Even sometimes if you find neovascularization in any place and you are wondering whether this it is a neovascularization or edema, you can do the OCT angio and you can just put the scan over the lesion. And if you found the flow, this means this is a neovascularization. Okay, this is just a simple a course. I hope that I fill most of the important points about the OCT and OCTA in wet AMD and diabetic macular edema. And hopefully I will able to see you in the next course to talk about the OCT and OCTA in other retinal diseases. Thank you very much, and thank you for your listening. Okay. Yeah. Yes. In all machines. Yeah. Yeah. هذا نسميه الفلو سكان. You can find it in any machine. Yes. قبل ما ننتقل في أي question من الأودينس. Yeah. But sorry, just to hear the question. Oh. Yeah. 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 Okay. Yeah. Now, some of the audience asking about the RPE detachment that not needing the treatment that I mentioned. I will back to the slides just to show you. Okay. Now in these types, we'll do nothing. We just observe the patient. Okay. There is no treatment because once you treat the patient, you will end with atrophy. Hopefully, in the upcoming courses, I will show you many cases with the such things that will not give any injection for them because there is no macular neovascularization. The rule in the injection, if there is a macular neovascularization, you have to inject because we are targeting neovascularization, not targeting the RP detachment alone. If you look to the sign here, no injection. If you inject, you will end with atrophy. And now we have a new terminology called non-exudative wet AMD, which means we have the changes of wet AMD, but there is no macular neovascularization. One of them is these three kinds of the neovascular of RP detachment. And the other one, if you remember, the SIRI, which means the shallow irregular RP detachment. We'll return back to it. This one, okay? This is also non-exudative. We have RP detachment, irregular like this, but it is shallow, not deep, and there is no fluid, okay? Like this case, like my case here. So there is no fluid. You can find there is no fluid, okay? Even if you inject, previously we were in treat these cases with the anti-VEGF, but actually nothing happened, okay? But you have to keep observing this patient because at any time he may get turned into the exudative type. Usually those cases sometimes may need 1 year or more to turn into the exudative type, but you can never guess when or at which stage they will be converted. So that just keep your patient to screening his or her vision, and you have to inform him when he get any drop in vision, he should come immediately to the clinic.
So we should do OCT NG.
Yeah, the cases of the silent CNV, you need, yes, the OCT angio, otherwise you cannot identify them. You will never pick up with the fluorescein. You're not able to see the silent CNV with the fluorescein angiography. But on the OCT angio, you are easily pick up the silent CNV. Yeah.
About the vascularized bruises.
Yeah.
One of the slides.
Yeah.
You talk about the vascularized.
Yeah.
And the prognosis date will be in AMD. So
it means the vascularized drusen, it means there is a high probability to getting the macular neovascularization. Yes. No. You just observe. Yeah. The vascularized drusen, it means on the OCT angio, there is a high flow over the areas of the drusen. So you need to pay attention at any time. These drusens will be converted into the macular neovascularization. That's why, in my opinion, for me, I am using the Triton machine. I have an access to using the OCT, OCTA at the same time to my patient. That's why I look into all modalities and make my assessment, multimodal imaging approach.
Question,
yeah.
Notes in this picture of the PIVAC is related to the mactil or it's different?
No, it's a different way on the mactil. Yeah, we will discuss the mactil in the upcoming courses, inshallah. The mactil and other retinal diseases that sometimes may be similar to the wet AMD or DME. For example, like a chronic CSC. No, it's not related to the steroid because you have a microaneurysm and you have the fluid, okay? When you inject the steroid, yes, regarding the fluid, but it's very resistant. It's very resistant, yeah.
In the OCT guidance, DME, hyperactive foci.
Foci, yeah.
Steroid or exposition?
Very good question. Yeah, the hyperreflective foci, actually, it's one of the inflammatory biomarkers. So their presence, especially in high numbers, it's an indication that this is an inflammatory-driven diabetic macular edema, not a VEGF. Because you know the diabetic macular edema started initially as a VEGF-driven, and then with the time started to be more inflammatory driven. So today we have like inflammatory biomarkers can tell you when you need to introduce the steroid. One of them is the hyperreflective foci, the subfoveal neurosensory detachment, one of these biomarkers, and the drill also.
Doctor, when it comes to the ischemic effect of the cystoid macular edema, you said it correlates to the size.
Yeah.
It also creates ischemic effect by affecting the deep capillary plexus rather than superficial one.
It affects both the plexuses, okay? Because at the end, we have the huge cyst, and this huge cyst is trying to press on the peripheral capillary plexus and causing the ischemia. Usually large cyst, if you look to the OCT, usually the large cyst extending not only in outer plexus, it extends to the whole inner retinal layers. Yeah. Any questions? Yeah. No. البيد yes.
الحالة اللي ورجيناها نعم. طيب سؤال جيد. هلا انا فاهم موضوع حتى نشرح الموضوع بدقه. هلا الار بي ديتاتشمنت للاسف هاي طبعا احنا نحكيها كثير من زملائنا حتى اطباء العيون اي ار بي ديتاتشمنت يشوفه راح معطيه انتي فيجيف. هذا this is a wrong تمام. احنا ليش احنا بدنا نتعلم؟ ليش جايين هذا الكورس؟ حتى نتعلم. هلا الار بي ديتاتشمنت اول شيء انت بدك تعرف الانواع تبعه. هلا انت عرفت الانواع تبعه اوكي. هلا انا مثلا شفت ار بي ديتاتشمنت